Good day, everyone. So at this point, I think you've already had previous video lectures in Module 1, particularly under Introduction to Research Designs, where you talked about randomized controlled trials, specifically the definition of what an RCT is, what are the types, and what are the phases. So just as a review, you could actually classify RCTs according to their primary objectives. And under that, you have superiority trials, you have equivalence trials, and non-inferiority trials. You can also classify RCTs according to schemes. And the previous videos covered parallel schemes, crossover trials, and factorial designs. Now, also in previous videos, you talked about randomization. Okay, you also talked about the different treatment groups involved in RCTs. Generally, they involve the placebo group and the treatment group. Now, the placebo group is named as placebo group if there are yet no known treatments for a particular disease. Now, if there already is a particular standard of care that is in place to treat a particular disease, and you want to test a new drug or new intervention to see if it's just as good as the standard of care, then instead of the placebo group, you have the control group or the standard of care group. Okay. Then also in those previous videos, we talked about what the null and alternative hypotheses are and what the differences between them. And in the previous video, you also talked about the advantages and disadvantages of RCTs, as well as the different sources of bias in RCTs. Now, what I mentioned in the previous slide should serve as the prerequisite knowledge that you will need for this particular video lecture. Now, basically in this video lecture, I will be focusing more on the design of an RCT, or rather how to design an RCT, the basic steps on how to design an RCT. So that involves formulating your research hypothesis, developing your protocol, although you will have separate lectures, or a lecture at least, that will talk about protocol development in more detail, right? So we'll also be talking about choosing the right population for your RCT. I'll be touching again on randomization, this time in a little bit more detail. Same thing with blinding. And we'll also talk about or touch on quality control measures that we need to observe when we are conducting RCTs. And on a final note, I will be talking about the ethics behind RCTs, or the ethics involved in conducting RCTs. Now, this video lecture is based on this article entitled Designing a Research Project, Randomized Controlled Trials and Their Principles. So if you want a copy of this article, you can request that from me. So I'll give that to you upon request. Okay. Now again, to reiterate, in this particular video lecture, I will be focusing more on the basic steps in designing an RCT, because as you've already been told, at least in the next few years in your medical school life, you will be expected to come up with a research project, at least as far as the medical research program is concerned. You're expected to come up with a research project which you will eventually implement, and if fortunate enough, get published, or at least get presented as a poster or conference paper in a particular conference. Okay. Now, if you decide, or if your group decides to come up with an RCT, then this video lecture should be an aid, or should be a guide to help you with the basic steps in designing an RCT. Okay. Now, you've already learned in previous videos that RCTs fall under this particular design group, so analytical experimental research design. Okay. So under this particular design, or under this particular type of research design, the investigator has direct control, at least in the assignment of subjects to comparison groups, and there's also control in the amount of exposure or intervention, or dosage of intervention the investigator gives to the study participant. And of course, not only that, the investigators also get to choose what type of participants they recruit and enroll in their study by virtue of inclusion and exclusion criteria, or eligibility criteria. one thing to keep in mind, though, with RCTs, randomized controlled trials, um, the investigator doesn't really have any control over the allocation, or rather the treatment allocation. That is, where would the um, participant eventually fall under? Would the patient fall under the treatment group, or would the patient fall under or get assigned to the control group? So we rely on the process of randomization for that in RCTs. Okay, so basically this is the minimum requirement for RCTs. There should be two comparison groups. So we have a treatment group, right? The one that receives intervention, and the control group, the one that does not receive the intervention, or at least receives the standard of care, if there is already a standard of care in place for a particular condition. Okay, and again, mind you, with RCTs, so the each participant is randomly assigned, or the allocation of treatment group for the participant is is decided by the process of randomization, and not as a decision of the investigator themselves. Okay. All right, so let's now begin with the design of your RCT. So RCT designs, or designing of RCTs, always starts with a good research question. And your research question, in order for it to have good characteristics, should follow this particular mnemonic, the finer mnemonic. So the research question should be feasible. So it should involve something interesting. It should involve something new or novel. It has to be ethical. Okay, so it takes into consideration the safety of your study participants, and it has to be relevant. So when we say relevant, so the subject to be addressed by your RCT should be of clinical, social, or economic significance. Okay, and because it is an RCT that you are designing, it should involve an intervention that you are assessing whether it's efficacious or not. Okay, and another very useful guide that you can use when you construct your research question, and this one you've already covered in previous lectures, is to follow the so-called PCOM or PECOM frame. Okay. Now again, since RCTs involve interventions, or an intervention compared to placebo in terms of efficacy, okay, we default to the PCOM frame rather than the PECOM frame. Okay. Okay, so let's look at a few examples of research questions in RCTs. So here's the first one. Is quadruple therapy better than triple therapy in the microbiological cure of tuberculosis among adult PTB patients in UMC for a particular year? Okay. Now, if we look at the PCOM frame, we can see that the P part of PCOM, patients, would involve the adult PTB patients being treated at UMC for a given year. Okay. The intervention that you would want to assess, or you're aiming to assess, would be quadruple therapy, and the comparison would be triple therapy, and your outcome is microbiological cure of tuberculosis. As for the M part, it's already understood that you're going to perform an RCT, right? Now, pay attention to how the research question was worded. Okay, so is quadruple therapy better than triple therapy? So this actually points towards a superiority trial that the researchers are probably aiming to conduct. Okay. Now again, this is just an example. We already know what the data is involving quadruple therapy versus triple therapy in curing pulmonary tuberculosis, right? Now here's another example. Is flubendazole just as good as albendazole in curing trichuriasis among two communities in Dasmariñas for a particular year? Okay. Now this particular type of clinical trial is what is called community trial, because one community will probably be randomly assigned to one of the two treatments involved, and the other would be randomly assigned to the other treatment. Okay, so this is an example of a community-based trial. Okay, now the population, or the P part of the PCOM frame, would involve residents of those two communities, right? The intervention that you would want to assess in terms of how well it is able to cure trichuriasis is flubendazole, with albendazole being the comparison drug, right? And again, we have cure again as the outcome for this particular RCT. Now, again, pay attention to how the research question was worded. Okay, you see here, is flubendazole just as good as albendazole, right? So this points towards or suggests an equivalence RCT or an equivalence trial that the researchers are aiming to design or carry out, right? So let's now look at the third example here. Is the use of chemical fogging effective in decreasing the incidence of dengue fever among residents of Dasmariñas for a particular year? Okay, again, we have P, or the population, as the residents of Dasmariñas, right? The intervention here would be the use of chemical fogging, with a comparison assumed to be not using chemical fogging. And this time, the outcome of interest would be the incidence or the decrease thereof of the incidence of dengue fever among the residents of Dasmariñas. And as with the first and second example, the M part of the PCOM frame is understood to be an RCT, right? Okay, so now that you have your research question, you can now construct your hypothesis, which you can derive from your research question itself. Okay, now as a review, a hypothesis is a statement that you can actually prove or disprove. Okay, now you need to have a hypothesis because it's so that statistical tests of significance can be performed, and your hypothesis also can be able to guide you as to what type of population to look for your RCT, right? Now, analytical studies need a hypothesis that specifies an anticipated association, okay, between a predictor and an outcome, right? So your hypothesis, again, should involve a predictor. In this case, this is the intervention or the type of drug or the type of intervention being given, and you have to have a clinical outcome or an outcome, right? So we talked about outcomes in previous examples of research questions in the previous slide, right? And then according to your hypothesis, you're anticipating an association between the predictor and outcome, okay? And again, we test this hypothesis by performing the RCT, and then we analyze the data to see if an association really indeed exists between predictor and outcome or not, right? So here would be an example of such a hypothesis, right? So you hypothesize that drug A is more efficacious in reducing the diastolic blood pressure than drug B in patients with moderate essential hypertension. Okay, so that's an example of a hypothesis, right? You hypothesize that drug A, or you hypothesize that the type of drug being given is associated with the outcome, that outcome being reduction in blood pressure, right? And then you hypothesize as well that drug A is able to reduce the diastolic blood pressure more than drug B, right? And one more thing about your predictor and your outcome is both of them have to be accurately measured, or you assign predictors or outcomes that can be easily and accurately measured, right? So in this case, the predictor is either the individual or the participant received drug A or drug B, okay? And then the outcome would be reduction in diastolic blood pressure. And that depends on what drug was received by the study participant, okay? Now, good hypotheses are specific and are formulated well in advance. Okay, so you might have encountered the Latin phrase a priori. Okay, so that means in advance, right? So good hypotheses, again, to reiterate, are specific and they have to be formulated in advance. Okay, so doing so actually makes sure that your choice of sample to be studied will be representative of that population to which you're trying to generalize your results to. Okay, all right. So again, again, this makes sure that your choice of sample will be studied will be representative, so that any results are appropriately generalizable to your target population. So we'll be talking about target populations later in this talk. All right, so let's now go back to the initial 3 examples of research questions that we touched on in a few slides ago. So let's talk about the first one. So this is the research question: is quadruple therapy better than triple therapy in the microbiological cure of tuberculosis among adult PTB patients being treated at UMC for a particular year? Okay, so that's your research question. So your hypothesis now would be, you hypothesize that quadruple therapy is better than triple therapy in terms of microbiological cure of TB, right? Now, in terms of predictor and outcome variables, the predictor variable here would be the type of therapy, okay? Whether the participant was randomly allocated to receive quadruple therapy or triple therapy. So you'll notice the I and C component of the PCOM frame are both involved as far as the predictor variable is concerned. Okay? Now notice that your outcome variable, cure, can be regarded as a dichotomous variable, meaning either the patient was cured of TB or not. Okay? And you'll eventually learn that dichotomous variables are expressed in terms of proportions or rates. So in this case, the outcome variable now becomes PTB cure rate. So is the rate of PTB cure higher or lower in quadruple therapy or vice versa, right? Let's now move on to the next research question example. So it reads, is flubendazole just as good as albendazole in curing trichuriasis among 2 communities in Dasmariñas for a particular year? So you hypothesize that flubendazole is just as good as albendazole in terms of curing trichuriasis, right? So what would be your predictor here? The predictor would be the type of antihelmintic to which the participant was randomly assigned. Okay, and 2 possible values or 2 possibilities for the predictor variable would be either flubendazole or albendazole. So again, it's a dichotomous variable. Either they got flubendazole or they got albendazole. And same thing with the outcome, right? Either the patient was cured of trichuriasis or not. And then with that, you determine you determine from the data what the cure rate is for trichuriasis. Okay, and then you see if the cure rate was actually higher with flubendazole or with albendazole or vice versa. Okay. Now let's look at the last example here. So is the use of chemical fogging effective in decreasing the incidence of dengue fever among residents in Dasmariñas for a particular year? So the predictor variable will be the type of aerosol treatment. So the intervention that we discussed earlier on in this particular question was chemical fogging, and the comparison would be not using chemical fogging or chemical pesticide. So in terms of research, so that there's a so-called blinding, which we'll be talking about later on, we make use of water vapor instead of the active agent or active pesticide for fogging. We're just trying to create this scenario wherein the residents might think that they are receiving the same thing when in fact it's water vapor. But of course, as part of ethics, they have to be informed that since they will be part of a research, they have to be well informed that there's a possibility that the fogging might actually be water vapor instead of pesticides. But we'll get to that later in the ethics part of this particular video lecture, right? And again, the outcome is again dichotomous, whether a particular resident from Dasmariñas developed dengue fever or not, okay, over the course of follow-up. And again, it's a dichotomous variable. And in this case, rate or incidence is actually congruent to the term rate. So in this case, our outcome variable was chosen to be dengue fever incidence, or dengue fever rate is also correct, right? And you'll notice that both predictor and outcome for all 3 examples are easily measured, okay? So with predictor variable, the researcher is able to ascertain that, or you're able to ascertain that one received this treatment or that treatment, okay? There are only 2 possible possibilities for that variable. Same thing with outcome, either cure occurred or not, or did the disease occur or not, okay? So those things are quite easy to ascertain. Again, reiterating that your predictor and outcome variables have to be variables that are easily and accurately measured, right? Okay, so once you've already chosen your topic for your RCT and you've already constructed your hypothesis to be tested by this RCT, you're now ready to write up your research protocol. And I believe you already covered this topic on research protocol writing or construction in a previous video in more detail. Okay, so I just refer you to that video, right? But it goes without saying that your research protocol outlines your proposed methodology, and it does this in the most comprehensive and thorough manner, right? Ideally, your research protocol has to be peer-reviewed, even better if it was reviewed alongside your research advisor, okay? Because it's better to do this because we want to make sure that no stone is left unturned in terms of errors. We've corrected all of the errors before we submit your protocol to ethics, okay? Because it's better to correct all errors while you're still in the design phase and not when you've already arrived as late as the analysis phase, because if that happens, more often than not, the results become invalid, or the validity of the results are put into question. Okay, so again, to reiterate, it's ideal that you review this thoroughly with your research advisor and peer review it if possible, because we want to correct any errors in your protocol, in your methodology, right at the design phase, as early as the design phase, not as late as when you already have the data and you're ready to analyze. Okay. And afterwards, once you're ready with your protocol, you then submit this for ethics review to make sure that the human subjects that you are enrolling or rather the safety of the human subjects that you are enrolling in your RCTs are ensured. Okay. Okay, so at this point, you've already selected your topic, you've already constructed your hypothesis, or reformulated your hypothesis rather, and you've already written your protocol, you've submitted it to ethics, you've already gained both technical and ethical approval of your protocol. Now you're ready to implement or carry out your RCT. And here are the steps, or the basic steps on how an RCT is conducted. Okay, so we'll go through them one by one. Okay, so the first step involves selection of the appropriate study population for your RCT. Now, come to think of it, selecting what study population you intend to recruit in your RCT happens at the point when you write your research protocol. Okay, so you define the study population that you intend to recruit in your RCT. So this particular step or this particular process is crucial because if your sampling is poor, let's say you selected a sample from the population and the sampling process was done in such a way that the sample that you were able to select from the population poorly represents that population, then that actually undermines the generalizability of your study results. So basically, if the sample that you derive from the population is not representative of that population, then you cannot be able to use the results of your study to that population, unfortunately. Okay. Now, what if sampling bias was introduced because of poor sampling? Then this also threatens the validity of your results. So this basically underlines the importance of defining properly what your study population is, or the study population that you want to include in your RCT. Okay, so to be able to do that, you first define your so-called target population, and you refer to your hypothesis for that to help you define what your target population is. Now, just to give you what, or rather, that's just to define, just to give you the definition rather of a target population. Target population is a population you intend to generalize or apply your results to, right? Okay, so properly defining your target population helps you decide what kind of participants to study and how to go about accessing or recruiting them, right? So let's say, for example, there was in a particular province in the Philippines, there was an unusually high prevalence reported of a particular micronutrient deficiency. Now, to address this problem, you want to design an RCT wherein you would randomly allocate residents from that province to receive either supplements of that micronutrient or receive a placebo, rather. Okay? And then you follow them over time to the follow-up period to see which arm would actually uh, correct the micronutrient deficiency. Now, again, this is just an example, so we're not. Let's not talk about the ethics part of this study yet. This is just an example, right? So your target population in this case would be the province, or rather the residents, or all of the residents in that province that has been affected by the high prevalence of micronutrient deficiency, right? Now, the problem is that province is vast, and you only have limited funds, and also because of logistical issues, you won't be able to sample the entire province because you only have access to one district of that province, right? So the accessible portion of the target population is what's called your sampling population. Okay, so you have to also consider logistics here. You have to also consider that, because of the vastness of the area that you're supposed to sample, you might need to just limit yourself to that portion of the target population that is accessible. Okay, your sampling population, and you have to ensure also that that sampling population should be at least theoretically representative of that particular target population to which you want to generalize your results to. Okay. All right, so now that you've defined what your target population is, the next thing that you need to define are your inclusion and exclusion criteria, meaning how eligible are the participants in joining your RCT, right? So when you construct your inclusion or eligibility criteria, you have to keep your outcome variable in mind. It would be best perhaps to include in your study those participants who appear to be at risk or have baseline characteristics that put them at risk for the outcome, let's say, for the outcome of interest. All right, so for instance, let's just limit ourselves to the San Beda campus, right? So let's say you want to conduct an RCT wherein you randomize students to either receive tutorial conducted by fellow students or receive tutorials conducted by the teachers themselves or the professors themselves, right? And then the outcome would be failure in a particular subject, right? So when you are considering or when you're constructing or formulating your inclusion or eligibility criteria, as I said, you keep the outcome variable in mind. So in this case, in the case of the example, I said that the outcome variable of interest would be failure in a particular subject. Now, who would actually be at risk for those? Who would actually be at risk for failing? Perhaps it would be those students who've had, let's say, the first 3 long exam scores, who have low scores in their first 3 exams. So basically, you probably would want to focus on those particular at-risk students and include them in your study, right? So, of course, we're not yet considering the ethics part here, but that's really merely just an example, right? So perhaps those failing students would perhaps be the best participants to enroll in your RCT because they are at particular risk for the outcome, which is failure, right? And either way, they're still receiving a particular intervention, so tutorial. The only difference is one group gets the tutorials from their top performing fellow student. The other group would be receiving tutorials from their professors. Okay. Now, how about exclusion criteria? How do we know, or how can we construct our exclusion criteria? Okay. So we think of participants who have conditions which may contraindicate the intervention to be tested. For instance, particularly when you want to test a particular pharmacologic intervention. Would would there be some participants in your included group who are actually or actually have contraindications to that drug? Let's say pregnant women. So if yes, then you might need to include pregnant women as part of your exclusion criteria, right? Now, another group of participants to consider as part of your exclusion criteria rather would be participants who will have difficulty complying with the required regimens. Okay. Now this is kind of difficult to determine, although there are certain strategies in terms of finding out if somebody will be compliant with the regimen or not. Okay. And of course, those who you think cannot provide, or those who obviously cannot provide informed consent, then for the safety of your team in RCT, so that there's no litigation, it's best that you exclude those patients who cannot provide informed consent. So again, these are just examples of how you can be able to construct your exclusion criteria. And again, it all depends. It would eventually declare itself basing on the hypothesis that you have for your RCT. Okay, and of course, you can always consult your research advisor when you are coming up with your inclusion-exclusion criteria, right? Okay, so you're now finished with defining your target population. You've already constructed what your inclusion and exclusion criteria are. The next step now, or the next sub-step for this particular step would now be determining what sampling strategy you will implement or you will use for your RCT. Now, with RCTs, simple random sampling would not cut it. Okay, so simple random sampling from the population is not appropriate when it comes to RCTs, simply because of the fact that you already have inclusion and exclusion criteria that you've defined. Okay, because doing simple random sampling just like that from the population would definitely include participants who violate your inclusion exclusion criteria. Okay, so for that matter, simple random sampling from the population is not appropriate. Now, one attractive sampling strategy would be the so-called convenience or judgmental sampling. It offers the advantage of having less expense in terms of cost, time, and logistics. Okay. The problem with convenience or judgmental sampling, however, is there's that danger of selecting a sample which may not be representative of your target population. And as I mentioned earlier, if your sample is not representative of the target population, then you won't be able to generalize your results to your target population. Okay? Now, if the outcome happens to be rare, then you might want to recruit a sample from populations who are at particularly high risk for said outcome. And we call this type of sampling stratified sampling. But at the end of the day, consecutive sampling from the accessible population or sampling population after, of course, after applying your inclusion-exclusion criteria still offers the best design for RCTs. Okay? And of course, you need to follow the so-called consort guidelines. So consort stands for Consolidation Standards of Reporting Trials, okay, in terms of population sampling. So it's a must-do when you're designing RCTs. So I've left the web page address here for you to check out. And again, as with the previous slides, it's always best that you are in constant contact or in constant communication with your research advisor so that you're guided as to what type of sampling strategy that you should use. Okay, so now that you've selected your sampling strategy, now need to determine how big of a sample size should you use for your RCT. Okay, so we're now into the subtopic of sample size calculation, right? So the sample size should not be too small that you won't be able to report any results of high precision or high accuracy. Okay, so there has to be a basis in which you calculate your sample size, and one such basis is deciding what a clinically significant difference is in outcome between your intervention groups. Right, so we call this difference the effect size. Now, just to name a few examples. Okay, so you want to conduct an RCT comparing two pain relievers. What do you consider to be a clinically significant difference? If is it the pain scale difference? So that pain scale being a pain scale from 1 to 10, would a 3-point difference in pain scales between the treatment groups be considered a clinically significant difference? Okay, that's one thing to think about. Okay, when you're comparing blood pressure medications, would you base your clinical, would you use a 10 millimeter mercury difference in systolic blood pressure as a clinically significant difference in terms of outcome between the two intervention groups? Okay, now going back to the hypothetical example that I gave regarding tutorials for failing students, would a 5% increase in exam scores be considered a significant difference? Okay, so those are things that you need to consider. Okay, so that particular significant difference is what's known as your effect size. So you as researcher yourself, have to define what the appropriate effect size is, and of course, it has to be backed up at least by prior literature. Okay. Then afterwards, you have to define what your alpha is and what your desired power is, right? So we normally default to minimizing our alpha or type 1 error to 5% or 0.05. So just to define what an alpha or type 1 error is, it's the error wherein you reject a true null hypothesis. Okay. Now, statistical power, we normally default to 80%, although we can always go higher than that. Okay, so using a statistical power or defining your statistical power of 80% brings your beta or type 2 error down to 20%. Okay, so just to define what a beta or type 2 error is, it's the error in you where there's non-rejection of a false null hypothesis, right? Either way, statistical consultation is necessary here, okay, because a statistician would know what appropriate formula or software to use in calculating the sample size after that statistician hears or reads your protocol. Again, stressing the importance that your protocol has to be very informative and comprehensive. Okay. Okay, so that is basically it with the step of selecting your study population, and I hope that was clear. Right? You can always post your questions in the discussion board in Red Canvas. So let's now move on to the next step in RCTs. That would be randomization or random allocation, right? And by that we mean random allocation of participants to either receive the treatment or the placebo control. So you'll notice I put an asterisk in the term placebo control because it all depends on the condition or the outcome being treated. So if it's a disease or a condition or an outcome wherein there's no established standard of care yet, then it's appropriate to use placebo. But if it's a condition that already has a current standard of care in place and you want to evaluate if a new drug is just as good as the current standard of care, then the control group would be the standard of care, and then the treatment group would be standard of care plus that investigational drug, typically, right? So because this whole thing has ethical implications, right? So I hope that was clear. Okay, so we now revisit the process of randomization, right? So this has already been covered in prior videos. But just to refresh your memory, so randomization is a process of assigning individual patients or individual participants to different treatment groups in such a way that each patient has the same chance or equal chance, okay, of being selected for any particular study or treatment group, right? So those are the main qualifiers in the definition of the process of randomization, right? So the whole idea of randomization is to make all study groups, or well, typically we have two study groups or two groups that we compare, uh, to be as equal as possible, okay, in terms of baseline characteristics right at the beginning of the experiment, okay? So we want to make sure that both known or measured and unknown or unmeasured baseline characteristics are the same for both groups, okay? Because such characteristics, particularly the unmeasured ones, are considered to be your potential confounding variables, which can distort the relationship between, or the association, the apparent association between predictor and outcome if we did not account or correct for it. Okay. Now, the process of randomization also reduces what's called allocation bias, and I believe you already covered the different biases in RCTs in the previous videos, so I just urge you to go back or prompt you to go back to those videos, right? So basically, the aim is to remove bias introduced by patients' individual characteristics. That's why we do randomization, right? So this process of randomization ensures that the baseline characteristics, they are typically demographics or risk factors or prognostic factors for the outcome of the study participants, have no influence whatsoever over the type of treatment to which they are allocated. And basically, after randomization, the only difference there is between the two groups would be the type of treatment, nothing else, right? Now, it's very important as well that the treatment allocations are concealed, right? And we ensure this by using a computer to generate the random allocation sequence. And then another common practice that is being done in RCTs is that the treatment assignments are sealed in opaque envelopes, and these opaque envelopes are given to the person responsible for administering the treatment, and it's only that person who would know what treatment was given to a particular patient. Okay, so treatment allocation concealment is important. So basically, the investigator should not know what the allocation sequence is, so that we avoid undue influence of such knowledge on how the investigators or the caregivers would treat their patients now that they know that this patient got the treatment instead of the placebo. Okay, so we'll go back to that again when we talk about blinding, right? Okay, now I mentioned earlier that the whole point of doing randomization is to balance or equalize the um, baseline characteristics of the study participants between the two groups. Okay, but it's always possible that the baseline characteristics are still unbalanced, and this usually is because of chance or due to chance between the two groups even after randomization. Okay, so this occurs when the sample size is small, again reiterating the importance of recruiting an adequate enough sample size for your RCT. Okay, now there are some remedies for that. So one would be what's called blocked randomization, wherein consecutively recruited participants are grouped into blocks of 6 or 8, for example, and then uh, equal slots for the treatment and the placebo or control group are allocated for that particular block. So the sequence is jumbled, and then that basically ensures that um, the participants are equal. Well, at least that's one way in which we try to ensure that the characteristics, baseline characteristics for of participants are equal between the two treatment groups, considering that the sample size is small. So I actually left here a YouTube link that you can go through, which actually briefly but eloquently explains how blocked randomization works. So I urge you to, or I suggest that you, or highly recommend rather, that you watch this video. It's a short video. Okay. Now, another thing or another remedy for this is to perform what's called stratified randomization, wherein randomization occurs within so-called strata in the population. Now, it's rather abstract, a little difficult to understand what this means, and because of that, I'll give you an example. So let's just say that you want to examine the effect of a treatment for heart failure. However, the degree of existing, or rather the severity of existing heart failure can predict the outcome of such treatment. So because of that, it's best to actually stratify your sampling population in terms of mild, moderate, or severe heart failure. And then you randomize using such strata so that you are ensured that the degrees of existing heart failure are balanced between the two treatment groups. Okay, so hopefully by giving that example, you were able to understand what stratified randomization means. Okay. Now, as a final note, before I leave random allocation to go on to the next step, okay, so once participants have been allocated to a particular group, they should be analyzed as part of that group, regardless of whether they comply with the treatment or not. So we call this type of analysis the intention to treat analysis. So you may have encountered this term before when you were reading some RCT articles on your own. Okay, so under intention to treat analysis, so data are analyzed according to how the subjects were originally intended to be treated. Okay, so basically the group in which the participant was allocated randomly at the beginning of the study, we keep that participant in that group when we analyze the data coming from them. Okay, regardless of whether or not they complied with the regimen or not, because this type of analysis actually provides the most valid results, because we are maintaining the balance between balance in terms of baseline characteristics between the two groups. Okay, so there's actually another type of analysis, the per protocol analysis, where we only include those who are compliant. So that actually has its own pitfalls, but typically or generally when we do RCTs in the analysis part, you have to perform what's called intention to treat analysis, and I've explained already what that type of analysis is in this slide. Okay, so let's now move on to blinding. So blinding in research is defined as the process of ensuring that almost everyone involved in the drug trial is unaware, so that's a key word there, unaware of who is receiving the experimental drug and who is receiving a traditional drug treatment or placebo throughout the duration of the study. So if you would state this differently, the study participant does not know whether he or she is receiving the treatment or the placebo. Okay. Now, blinding should not be confused with allocation concealment, right? So allocation concealment is one that occurs before the randomization process. Blinding occurs afterwards, right? Now, the most common way of ensuring blinding, or the most common way of doing blinding, is to make sure the treatments being compared are indistinguishable from each other. So what does this mean? So for one thing, the two preparations look similar, right? The the look and feel, or the look and color of the pill of the treatment looks the same as that of placebo, and vice versa. So there's no way telling apart which is placebo, which is the investigational treatment. Now, there will be instances wherein blinding becomes impossible, or difficult for that matter. That is when the intervention is a diet, for example. So the participant can easily determine, okay, I was actually allocated to this group rather than the other group. So another one would be when the treatment, or rather when the interventions are maneuvers instead of pharmacological agents, or when the interventions themselves are surgical procedures. Okay, so that's a little difficult to perform blinding on. Okay? Okay, so blinding is a very important part of an RCT, or the blinding process is a very important part of an RCT, because if participants or investigators, for that matter, are not blinded, then the following things can happen. No? So knowledge of the drug can influence the assessment of patients receiving them. Okay, so this happens particularly when the criteria for making a diagnosis of a particular outcome has some subjectivity to it. So if the one assessing or ascertaining the outcome knows that this patient is receiving the treatment, it may actually influence their decision whether or not the outcome in question has been achieved or has been attained or not. Okay, hence the importance of blinding the outcome assessors as well. Now, knowledge of the physician, if ever the physician is a part of the research team, if the physician has knowledge about the drug or intervention the patient is receiving, this actually can influence how he or she would treat them. So if the physician is aware that the subject or the participant is receiving placebo, then of course, for fear that this participant might be at higher risk of getting the negative outcome, then that physician would actually be concentrating more on that particular patient's care, and that actually could influence the outcome of the study, right? Now, you may have come across the terms single-blinded, double-blinded, triple-blinded. So this is what it means. So if an RCT is said to be single-blinded, then it's only the study participants who do not know what type of intervention they're receiving. When you say double-blinded, is both the study participant and the investigators who are unaware of the treatment allocation. So neither the study participant nor the investigator knows which intervention or which drug or which treatment was given to the study participant. So when we say triple blinding, that actually now involves the data evaluators or outcome assessors. Okay. Okay, so you've now blinded your participants, and your participants have now received the intervention, or the placebo for that matter. So what is the next step or what is rather the next order of business? The next thing to do is you now follow these patients up throughout the follow-up period and see at the end, or along the follow-up period, whether the outcome has been attained or not. Okay, and of course, this outcome has to be ascertained according to the criteria that you set for diagnosis of said outcome. And you would need the help of outcome assessors to do that for you. So outcome assessors are study personnel or members of your study group who are responsible for deciding how a patient responded to therapy, meaning they're the ones who assess and ascertain whether an outcome has been attained by a study participant or not. Now, pretty straightforward if the criteria for ascertaining the outcome is objective. But what if the criteria is or has some subjectivity to it? Then, of course, that becomes a more difficult job for the outcome assessors, and it's which is also important. Why, as much as possible, the outcome assessors have to be blinded as well as to what the treatment was that the study participant received, so that it does not influence them to decide if the outcome was attained or not in that particular patient, particularly if the criteria to ascertain the outcome has some subjectivity to it. Okay. Now, here's a reality of research. No? So there will be participants who will drop out at some point along the follow-up period. Okay, they will either drop out or get lost to follow-up. Okay, so what could be possible reasons for that? So it could be because of adverse effects from the intervention, or it could be just overall dissatisfaction with the way the RCT was conducted. Okay, so that's why you always have to make sure that before you implement, everything is all straightened out at protocol level at the very beginning. Okay. Now, and why is this important? Because the higher the dropout rate, the greater the threat is to your study result validity, right? Okay. And as much as possible, the outcome assessors have to contact those who are lost to follow-up or those who dropped out and ask them simply, okay, or try to find out whether or not these dropouts or those who were lost to follow-up attain the outcome or not. Okay, so training has to be done so that outcome assessors should be able to contact them, and for that matter, study participants should leave their contact details, okay, so that they could be contacted even if they dropped out of the study to be able to ascertain the outcome. Okay, so at this point, you should have already ascertained the outcome. You already have information or data about the outcome or whether or not the outcome was obtained by the study participants in both treatment arm and placebo arm. Now, what are you going to do with that data now? So use that data to compute for what's called your outcome measures, or more accurately, your treatment effect measures. Okay? Your treatment effect measures are numerical measures that are used to compare the effectiveness of the interventions in an RCT. So you basically use data on outcomes, okay, for treatment group and for the placebo group, right? So you compare, and that's where you compute your treatment effect measures from, okay? So these measures should be appropriate as well to the research question, which reiterates why you have to make sure that your research question and your research objectives, for that matter, are congruent with the selected outcomes and the methodology that you laid out in your study protocol for your RCT, right? Okay, and then you make sure from the beginning that the outcomes of interest can be measured accurately and precisely. So as much as possible, you don't give any vague criteria for diagnosis or for determining what the outcome is. Okay, so you have to make sure of that, so that your outcome assessors will not have a difficult time in ascertaining whether the outcome was attained by a particular study participant or not. Now, in terms of computing for your treatment effect measures, it's always good that you are familiar with the nature of your outcomes. Okay, what kind of variables are your outcome variables? Okay, so your outcomes can either be dichotomous in nature or they can be continuous in nature, right? So when we say dichotomous, meaning there are two possible answers, either the outcome was obtained by the study participant or it was not. Okay, so pretty straightforward. And fortunately for us, many RCTs make use of dichotomous outcomes. Now, how about continuous outcomes? When we say that an outcome is a continuous variable, it takes on an unlimited possible number of values. So a very good example would be, let's say, temperature. You can have 36.5, you can have 36.4, 36.3, and so on and so forth. So there's actually many possible answers or many possible values that that particular outcome variable can have. Okay, another example would be blood pressure, right? Weight, height, blood levels of a particular compound or blood marker, for that matter. Okay, now let's go back to dichotomous outcomes. So as I said earlier, when we say dichotomous outcomes, either the participant obtained the outcome or not at the end of the follow-up period. Now, dichotomous outcomes are expressed as proportions, right? So example would be 2 deaths per 100 patients, or they could be rate. They could be expressed as rates, okay? So when you say rate, there's actually a time component or time component included in the expression or in the measure, okay? So example would be 5 deaths per 100 patients per year, right? And from these proportions, we're able to derive these treatment effect measures, okay? Your relative risk, which is actually a measure of association, your relative risk reduction, and your absolute risk reduction. So the last two are measures of impact, okay? Now, how about with continuous variables? So continuous variables are expressed as means or averages rather, okay? And how do we determine if one treatment was better than the other? So we determine what's called the mean difference, which is simply the difference between the mean of that outcome or average of that outcome in the control group and the mean of that outcome in the treatment group, okay? So it's very easy to compute, really, quite straightforward, okay? Okay, so let's start off with relative risk. So the formula for relative risk would be the proportion or rate of the outcome in the treatment group over the proportion or rate of the outcome in the control group. Again, so pay close attention. The numerator, the value for or the proportion of the treatment group should be in the numerator, while that of the control group should be in the denominator. Okay. Now, if you would express RR differently, it would be this one. So the new risk. That would be the proportion or rate of the outcome in the treatment group. You can also call that your new risk, okay, which means that this is now your risk for the outcome after receiving the treatment, okay? And then you compare this with the original risk. Had you not received the treatment, this would be your baseline risk, okay? So basically the whole concept here is the treatment is the one that's expected to change your baseline risk, okay? That's why it says new risk when we talk about the proportional rate of the outcome in the treatment group, okay? And we could actually abbreviate these terms into R sub T, which pertains to the risk, relative risk for the treatment group, and then R sub C is the risk pertaining to the risk in the control group, okay? Now, since it's a ratio, of course, you have a numerator and you have a denominator. Now, what if this ratio or fraction has a value that is less than 1.0? Okay, so when you have a fraction whose overall value is less than 1.0, it means that the value in the numerator is lower than the value in the denominator. So this means that with the treatment, the risk for obtaining the outcome is actually lower in the treatment group compared to that of the control group. And the overall fraction would now give you a quotient of less than 1. And with that, it means that the treatment is beneficial because it effectively lowered the risk for the outcome or the rate for the outcome among those in the treatment group. Now, if they're the same, okay, the risk of obtaining the outcome in the treatment group is just the same as that in the control group, then that means that the numerator is equal to the denominator. You do the division and you get 1.0, meaning the treatment really has no effect. And mind you, since we're dealing with fractions here or ratios here, the null value, the so-called null value or the value of no effect, in this case is 1.0. Okay. Now, what if the risk for the outcome is actually increased in the treatment group, or if the risk in the treatment group is higher than that in the control group? So this now makes the numerator's value larger than the denominators. So that would give you a quotient of more than 1. And that would tell you that because the intervention actually increased your risk for obtaining the outcome, then this new treatment now is actually harmful instead of beneficial, right? Okay, so now how about with relative risk reduction? So RRR is equal to a change in your risk that is the difference in the risk between the treatment group and the control group, or the original risk, all over the original risk. Okay, so expressed differently, it's this. So it's a quantity R sub C minus R sub T all over R sub C. Okay. Now, again, let's say the treatment has benefit, and that means that the risk in the treatment group is lower than the risk for the outcome in the control group. Then that means that the difference in the parenthesis in the numerator of RRR would be more than 0. Okay. Now divide this non-negative number by the original risk, then you get an RRR more than 0. That means that the treatment is beneficial. But what if the risk in the control group is just the same as the risk for the outcome in the treatment group? So the numerator with the quantity R, the quantity R sub C minus R sub T would be equal to 0, because the risk, or their values, are the same. It means that there's the risk for the outcome in the control group is the same as the risk in the outcome for the treatment group. So the numerator of your RRR formula would be 0. So now this would mean that the treatment has no effect at all. And since you're dealing with differences here, in this case, 0 now becomes your null value, or value of no effect, right? Now, similarly, if the RRR is less than 0, that means the risk for obtaining the outcome is much larger in the treatment group than in the control group. Okay, and that now means that the treatment is actually harmful, right? And then we move on to absolute risk reduction, or ARR. So the concept here is much simpler, because we're simply looking at the difference between the risk for the outcome in the control group and the treatment group, right? So same concept applied here as the same concept applied with the RRR. Okay. Now we don't stop there with the ARR though. There are actually two other important measures that you can derive from ARR. Now, assuming the ARR is more than 0, that is, the treatment is beneficial, you will be able to compute for what's called the number needed to treat. You simply get the reciprocal of the positive value for ARR. So what does this mean? So the number needed to treat would be the number of patients with the condition that the treatment is trying to treat or cure. So basically, you need to treat these many patients before you'll be able to observe one beneficial effect, or one desired outcome in this group. Okay, so basically, the lower the number needed to treat, the more impactful, or the more beneficial the interventional, or the investigational intervention is, or investigational drug is. Okay. Now, what if your ARR has a negative value? If you get the reciprocal of that, you get what's called now the number needed to harm, right? So this is actually the same similar concept as with number needed to treat, but this time what it means is this would be the number of patients you need to treat first for the condition the medication is expected to treat before you observe an untoward outcome in that group, right? So again, same concept. The lower the number needed to harm, then the more harmful that new intervention, or that investigational intervention is, right? Now let's try to make use of the weight analogy when you're interpreting RR, ARR, and RRR. Okay, so for instance, you started on an intervention, a particular exercise and diet program. It actually changed your weight from a baseline of 80 kilograms to a new weight of 60 kilograms. Okay, so your 80 kilograms here would be your baseline or control weight, and then your 60 kilograms would now be the new weight that you were able to obtain after undergoing said intervention or said diet and exercise program. So let's just try to express ARR in terms of absolute weight reduction. So it's 80 minus 60. So basically, you express this as, okay, this is the amount of weight that I've lost, or the amount of risk, for that matter, for the outcome that was reduced after giving the intervention. Now, how about with RR? Okay, so again, go back to the formula for RR. So it's the we view weight here as risk. So it's risk or weight in the after getting the intervention over the risk or weight that you would otherwise get had you not have taken the intervention. Then it's 60 over 80, then it's 0.75. So the way that you say this now is you now weigh you now weigh 3/4 of what you used to weigh. Okay, so you've now reduced your weight or risk down to 75% of what you originally weighed. Okay, now how about with relative risk reduction or relative weight reduction for that matter? Okay, so applying the formula, you get 20 over 80, and it's 25%. So we regard RRR as the amount of risk that was lost or added if the treatment is harmful. RRR would now be regarded as the amount of risk that was lost after you have received the beneficial intervention. Okay, so basically after doing the exercise and weight program, you have lost 25% of your weight. Okay, and notice that RRR in this case would be simply 1 minus RR. So try to go back to the formulae for RR and RRR, and you will see that RRR can be reduced or can be restated as 1 minus RR. Okay. Now, let's make use of an illustrative example to be able to understand or to appreciate how these three effect measures work. Okay, so researchers conducted an RCT to determine the effect of dietary supplementation of omega-3 fatty acid on cognitive ability among children 12 to 17 years of age. So basically, there was a total of 1,000 children, 500 of which were randomized to the treatment arm, and the other 500 were randomized to the placebo arm. So after a follow-up period of 2 years, the outcome assessors ascertained the outcome. Okay, so they followed the criteria as stated here. So the outcome here is defined as whether or not they had low scores in a standardized cognitive test. So here were the results. So at the end of the 2-year period, 200 children out of the 500 in the treatment arm scored scored low in the cognitive test, while 300 children in placebo arm scored low in that same test. So how do we now compute for the treatment measures here? Okay, so you have learned in a previous video from an earlier module that in such cases you construct what's called a 2x2 contingency table, or a contingency table for that matter. Okay, so you tabulate here the number of children who scored low in the test among those who received the treatment and among those who received placebo. Okay, and then conversely, also record the number of children who did not score low in those tests, and you have these values here that you see in the table. Okay, so let's now first compute for the risk in the control group, right? So that would be simply 300, meaning the number of children who scored low, all over the number of children in the placebo arm. Okay, and then how about for R sub t? So it's now 200 over 500. And then from there, now that we've defined our R sub c and R sub t, we're now ready to compute for RR. So it's R sub t over R sub c. So we get 0.67, which means that with omega-3 supplementation, this actually reduced your risk of obtaining a low score down to 67% of what it used to be at baseline, right? Now, conversely, this means also that with the supplementation of omega-3, your risk for obtaining a low score on cognitive test was reduced by 33%. Okay, and the absolute reduction in this case would be 20%. Okay, so you have there was a 20% difference in terms of risk between treatment and placebo arm, risk that is in terms of scoring low in a standardized cognitive test. Okay, so hopefully this illustrative example made it easier to understand the concepts of RR, RRR, and ARR. Okay. Okay, so there's actually another thing that you need to understand about relative and absolute risk reduction. Okay, so the RRR tends to be more stable in terms of value than your ARR. And this all depends, and the value for your ARR actually kind of depends on, for one thing, on the size of the sample size of the clinical trial and the type of population being tested. Okay, so let's just take this hypothetical RCT for instance. So you perform the RCT twice. First was with a group of patients who are high risk for the outcome, and another group would be those who are at lower risk for the outcome. And notice that there's actually a smaller number of participants in the lower risk patient population. So let's try to compute for the measures for RCT1. Okay, so you have an R sub C of 40%, you have an R sub T of 30%, you get the relative risk or risk ratio, you get 0.75, and RRR of 0.25. So it's simply 1 minus 0.75, you get 0.25, and 25% for that matter. And notice the ARR, it's 10%. Okay, so there's a absolute reduction in risk by 10% because of the treatment compared to placebo. Now let's look at the values or the measures in RCT2. So there, notice now that R sub C is 10%, while R sub T is roughly 7.5%. Okay, so there's now with the low risk patients, of course, the impact is not that strong as opposed to high risk patients. So if you're high risk for the outcome, then you would actually gain more benefit from the treatment as opposed to when you are low risk for that outcome. So you get lesser bang for your buck, so to say. So for that matter, after receiving if you're low risk for the outcome and you receive the treatment, your risk is, let's say, 10% for the control and risk of 75% for the treatment. There's really not much difference. But if you would compute for RR and RRR, they're basically the same as with RCT1. But this time, look at the absolute risk reduction. It's now down to 2.5%. Okay, so basically, which really shows that which really shows the nature of these measures being measures of impact. Okay, so takeaway from this slide is that if you're of a low risk profile, then maybe you don't get that much benefit from the treatment as opposed to when you have a high risk for the outcome. So it's important to understand this kind of concept because sometimes there may be pharmaceutical companies that would report the RRR and conveniently not report the ARR. So if you know how to appraise the data, then you can be able to derive these measures. Okay, and from there you could be able to decide, okay, maybe this treatment may not necessarily be that useful for my particular patient, given that my patient that I'm treating has a lower risk for the outcome. Okay, so hopefully that was clear. Okay, so at this point, we've already basically covered all of the basic steps in conducting an RCT. Right, so I hope at this point, if ever you would try embarking on a small-scale RCT for your research project, hopefully you'll be more confident now on how to design one. Okay, and by all means, you can always consult your research advisor if you have any questions or clarifications regarding your protocol. Now, as I mentioned earlier, I will be touching briefly on quality control in RCTs and as well as ethical considerations before ending this video lecture. Now, when we talk about quality control in RCTs, keep in mind that large-scale RCTs or pharmaceutical RCTs are very expensive, and there has been a lot of money invested in it. I mean, just look at the news. You've been hearing about many clinical trials on the coronavirus vaccines. Okay, so these are expensive undertakings, right? So it involves a lot of money invested, okay, because it involves a lot of manufacturing of the drug, and the conduct of the RCT itself is also expensive, right? So it's required that everything is of quality. So you allow no chance for any error to happen, because if your data is poor, or if the quality of your data is poor, or the quality of methodology is poor, then you basically just wasted money, and then this may actually be giving you more harmful misinterpretations of the data, which can actually send harmful rippling effects if ever this product was approved and is now in the market. If you have shoddy data, that means this could actually be potentially harmful for those who will be using this new intervention. Okay, so you have to ensure, as investigator or as designer of your RCT, you have to ensure that quality is observed at every step of the process. Okay, so when it comes to data collection, okay, make sure that there are no missing or inaccurate measurements. You have to train your data collectors well. Okay, so any outcome measurement taken on a patient should be precisely and reproducibly measured, right? So the measurement should be reproducible, meaning if there's a different outcome assessor who will measure the outcome, it would give you more or less or pretty much the same result as what the previous person did in terms of measurement. Okay, so as much as possible, you don't allow any room for wide inter-observer variation. Okay, so that means that you have to calibrate your measuring instruments very well, right, to minimize any problems with precision and accuracy. Okay, so you also have to ensure that your protocol is followed by the book. Okay, so you have to give proper instructions in operations manual for your study personnel so that they are fully familiar as to how to conduct the methodology of your RCT. Okay, now you as primary investigator or PI, you also have responsibilities as well for this RCT. You have to attend investigators' meetings, because that's where important information is being conveyed by the sponsor to the principal investigator or PI. Okay, make regular visits to your study sites and with your team members, because it actually ensures that, or this actually allows good communication, supervision, early detection of problems, and you're able to get feedback in case there are any rough edges or rough patches along the conduct of your RCT. Okay. Now, quality control also involves data management, right? So the forms that you will be using for your RCT should be easily understandable, they're appropriate, they're user-friendly, they're self-explanatory, okay? So they should contain statements or instructions that are at most fifth grade level of comprehension, okay? The instructions are clearly formatted, right? And these forms are only asking for data that is needed for your RCT, nothing else, right? And for that matter, you should be able to maintain a computer database, and this database is designed in such a way that's easy to encode and transcribe the information that was collected or that was recorded in those forms. Okay? Now, of course, another reality of research would be at some point along the conduct of your RCT, you may need to make some adjustments in your protocols. Okay, so these are called protocol deviations, and you have to inform the ethics committee if such deviations occur, particularly if the deviations are major ones. Okay, as much as possible, you keep these changes to a minimum, right? And revisions should only be undertaken if, after careful consideration, it is felt that making such changes will significantly improve the study findings, or not changing the protocol will seriously jeopardize the project or patient safety. Okay, so as much as possible, that would be the only reasons why you would make changes to your protocol. Because right from the start, you have to ensure that everything is already well planned out in your protocol before you send this to ethics, to technical review, and then once you conduct your RCT, it should, as much as possible, go smoothly because you've already ironed out or you've straightened out all the kinks right at the beginning, at the design phase of the study. Okay. Now, if there are any changes, this has to be well documented and dated and disseminated to all investigators and study personnel so they are fully informed of such changes, okay, so that no mistakes will be committed along the way that can jeopardize the study's validity and patient safety for that matter. Okay, so the last part of this video lecture will be covering on ethical considerations. So to some extent, you've already covered this under protocol development in the previous video by Dr. Mark Bessa. So basically, the dictum here is the study or your RCT should not start unless ethical approval or ethics approval has been obtained. Okay, so very important. So when you draft your protocol, you have to state or indicate whether the procedures to be followed in your RCT are in accord with the so-called Declaration of Helsinki. And this is particularly important when your subjects are human or human subjects are involved in your study. Okay, so basically the World Medical Association has developed this Declaration of Helsinki as a statement of ethical principles to provide guidance to physicians and other participants in medical research involving human subjects. Okay, so you can actually check this website out to get more details on the Declaration of Helsinki. Right, so it's a must see or must read if you are going to design an RCT. Okay. Okay, so ethical considerations should discuss the following issues. First, okay, participation in this RCT should be voluntary, okay, and it has to be reiterated to the participant that participation is voluntary, it's not coerced, and they have the right to withdraw from the study anytime they want, okay, at any stage of the study, and you have no right to keep them in the RCT if they do not want to continue with the study, right? And the respondents should also participate based on informed consent. So this means that you inform the participants of all pertinent details regarding the RCT, right? What kind of medication is being given. There's a possibility of being randomized to the placebo group. What would be the possible benefits and side effects of said medication, and so on and so forth. So not only should you inform them, you also have to make sure that they understood everything, okay? And then they are provided with what's called an ICF, or an informed consent form, which they can take home with them for their perusal, okay? So they have something documented that they have been informed of the details, the pertinent details of the study, and they understood the implications, okay? And also reiterate that everything is voluntary. There should be no pressure or coercion, okay? For that matter, if there are also standards in terms of monetary compensation for the subjects, it should not be too exuberant that the participants are now enticed to participate. This is actually considered a form of coercion. Okay, so you also have to follow certain standards in terms of monetary compensation. Okay, and importantly, the use of offensive, discriminatory, or other unacceptable language needs to be avoided in the formulation of the questionnaire or the interview or the focus group questions. Right, so that's pretty self-explanatory. Okay, so here are the other things that have to be discussed under ethical considerations. They're all pretty self-explanatory as well. So there should be privacy and anonymity of the respondents. Okay, that's of paramount interest. Okay, so you should maintain the highest level of objectivity in discussions and analyses throughout the research, right? And very important, you have to observe data privacy laws in effect. Okay. Okay, so under ethical considerations, the following points should also be explained. Okay, so the benefits and risks for the subjects involved. So you actually can cover this also in your informed consent. Okay, what would be the physical, social, and psychological implications of the research, right? So what would be the potential benefits to society, if ever, if not at the individual level? Okay, so you should also provide details of the information to be or rather, details of the information to be given to the study participants should be provided as well. Okay, so it really is just a repetition of what I explained earlier, that part of the informed consent process is the participants or the potential participants are well informed of the pertinent details about the RCT. So once they are now informed of, they are now given that information, they can mull over or think over it before they participate. So basically, after considering everything, they decide, okay, I'll participate in your study. I give you my consent. They sign the form, and then you have something that safeguards you and shows that you're not coercing them or forcing them to participate in your study in any way or form. Okay. And lastly, information should be provided on the free informed consent of the participant. Okay, so the details should also be indicated in the ICF or the informed consent form too. Right? So again, these are all pretty self-explanatory. Now, for the 10 most important principles involved in ethical considerations, I will not be going through them one by one anymore, again, because they're pretty self-explanatory. And I'll just leave you, I'll just leave this for you to read one by one. Okay? And I left the source of this as well if you're interested in reading more about them. Okay? And that effectively ends my lecture on the design and conduct of RCTs. Okay, so thankfully it's just a little bit over an hour and a half, not over 2 hours. So hopefully at this point you now feel a bit more informed and confident if ever you decide eventually on choosing at least a small scale RCT in the school setting for your research project. Now, if you have any questions, feel free to post them in the discussion board, or you can also message me directly through the messaging system of Red Canvas. So I end this video lecture here. Thank you very much for your attention, and good day.